Welcome to the podcast. I'm your host, Jim Jorgenson, and today we're joined by Dr. Jenna Swindler, Vice President of Pharmacy Services for the McLeod Health System in South Carolina. And we're going to be focusing on systemness in healthcare. So welcome, Jenna.
Yeah, thank you for having me.
Absolutely. Let's start with an intro to the audience for people that don't already know you. Can you give us a little bit of your career background and how you got to where you are today?
Yeah, absolutely. So I was born and bred at McLeod, so to speak. I am from Florence, South Carolina originally. I went to pharmacy school at the University of South Carolina in Columbia, and then came back to Florence to do my postgraduate year one at McLeod. I was fortunate enough that they had a program here. I had done some rotations and really just loved the culture, loved the relationship between pharmacy and the medical staff that was at the facility, and knew that was where I wanted to train and would be able to grow. From there, I was able to secure a position as their first antimicrobial stewardship pharmacist and really be able to start that program back in 2010. I stayed in that role as a clinical specialist in ID for about 5 years and then moved into a clinical manager role for McLeod Regional Medical Center. I was in that role for 4 years and then pivoted over to our organization's operational effectiveness team, where I got to learn a lot more about hospital and health system operations, went through some lean training, and then moved into our continuum of care division. And I think my time in the continuum of care division really showed me a different side of pharmacy and what pharmacy has to offer to a health system, and how we can be that profession that really stands in the gaps for our patients in between acute care and ambulatory visits within the health system. So from that role, I became very interested in the newly established VP of Pharmacy role at McLeod Health and have been fortunate enough to be in that job now for about a year and a half.
Well, did you ever envision yourself in that role when you first started out as a clinician?
Not really. I used to think, who would ever want to be in administration? Why would you ever want to do that? I loved taking care of patients. Loved the ICU. I loved rounding with providers. But as my career went on, I really began to see that if we didn't have leaders in administrative roles within pharmacy who knew the potential of what we could do down to the patient level and how we really impact bedside decision making, that we wouldn't continue to grow as a profession. And so I felt like my knowledge and my passion in that realm was very helpful to the administrative team, and really have, kind of kept the patient at the center of everything I've done, no matter what role I've been in. And so I think it's really helped me to be able to grow and get into some different things that could help us help patients be more connected in their journey.
Very true. How about McLeod itself? Give us an overview of the system and maybe a thumbnail sketch of your pharmacy operations.
Yeah, so McLeod Health is a 6 hospital health system, but we have around 100 physician practices. So that's primary care, peds, different specialties. We have 2 hospital-based infusion centers that are attached to our cancer services, and then 3 additional hospital-based infusion centers located in our rural markets. Our flagship facility, which is McLeod Regional, is around 500 licensed beds, and every other facility we have, the next largest is around 200 beds. So we do span across rural South Carolina, and so that can make the way that we service those patients a little more challenging based on what they have access to and the communities that they live in. We also have 2 outpatient pharmacies. Both of those are connected to our larger hospitals. And they, service our meds to bed population, service some of our specialty pharmacy patients from our oncology practices. And then, of course, our 6 acute care pharmacies, which have clinical services spanning from antimicrobial stewardship to ICU to infectious diseases and many other specialties. One of the things that's kind of unique about our area of the world is we do have a very large chronic kidney disease population. And so we have pharmacists who specialize in hemodialysis. It's very important to get all of that dosing correct. And so that's kind of an area that we are able to offer residents, learners, and providers even more information about how important it is to get the dosing right in that population.
Excellent. Let's talk about the concept of systemness, which is obviously becoming increasingly important in multi-hospital organizations. And It seems to me there's almost three distinct life cycles or phases in that journey. I think first off, you get hospitals that say, "Oh, let's form a system," and it's actually more of an affiliation because the only thing that really changes are the logos. And then I think you kind of move into a coalition where they begin to standardize things like IT or purchasing or human relations, but they never move much further beyond that. And then finally, you get to that true systemness where, clinical services become integrated, like pharmacy as an example. So how does McLeod define systemness and what role is pharmacy playing in achieving it?
So it's funny that you say that about only changing the logo and really just kind of being affiliated. One of our CEOs at one of our facilities said that for a long time we were a confederation of like hospitals, and I think that's what happens to most systems as you're acquiring and trying to bring up operations at certain facilities that may have been struggling. It's really hard to just come in and say everyone's going to do it this way because one hospital does it this way. Just because one hospital does it that way doesn't mean it's the right way. And so learning how we begin to pivot and flex as a system is incredibly important. Pharmacy really has been one of the first clinical areas within McLeod Health that has taken more of a systematized approach to how we are going to operate and how we are going to provide care to patients. I think we were in a unique situation because we don't have 24-hour operations at all of our hospitals within our system. And so, of course, at night, we become one system, whether we want to or not. The pharmacists who are servicing from our flagship hospital are taking care of patients at all the other facilities. And so, in order to do that safely and efficiently, we really had to come together even before pharmacy became a system function. We were coming together as an affinity team of all the different directors and all the different stakeholders within pharmacy to say, how can we do this better? How can we do this in the safest manner possible? What's going to be easiest for the nurses? What's going to be easiest for providers? How do we get the formulary all aligned? And those are hard conversations to have. There's a lot of reasons that we have all done things the way that we did for years and years and years, but there are a lot of new reasons why we need to change. Unfortunately, we went through several years of significant change within our organization. We pivoted from one EHR to another and then to another, all within the span of about 4 years. And nothing will make you become a system quite like an EHR implementation. So that really began to strengthen our team from a pharmacy perspective to, be able to decide on how we wanted to build things, how we wanted to operationalize things. And so I think we were able to pioneer in the sector of systemness a little sooner than some of our other colleagues in other professions across the system. From an administrative standpoint, I really think that McLeod has always been all in on wanting to do things the best way possible, but not standardizing just for the sake of standardizing, really doing it because there was a good purpose or a good reason. If something didn't have to change within local operations, we weren't forcing that to have to happen because we need people to be able to operate on local levels, but support system goals. And so I think that's the perspective we have, is that you don't standardize without a good why, but you also don't create variation without a good why. And that we try to move with each other's goals in mind so that we move as one instead of moving as a confederation of like hospitals.
Yeah, exactly. And I've always felt that pharmacy had an advantage in that process because we already talk to each other, probably more so than most other professions.
Absolutely.
So, what kind of an infrastructure do you have to ensure consistency or to support consistency across the pharmacy practices in all your different locations?
So one of the things that we set up pretty early on is our pharmacy operations team. We really had a great backbone of that already from our working affinity group, but we began to expand that operations team and really parse out what should be a system function versus what should be a local function. With that, we created some great system roles like a pharmacy business director so that we're able to have someone who is the liaison to finance and to rev cycle, because there are so many unique things about pharmacy. We're battling not only medical benefit payers, but PBMs. We have to be able to think about real-time claims adjudication versus denials from prior authorizations. And so we really wanted someone who could give pharmacy kind of a unified voice with our finance partners and our rev cycle partners so that we began to create a better understanding of what is the business of pharmacy. And that gave our operators a little more time to operate in their outpatient pharmacies or, within their acute care pharmacies. The other thing that we created is a system med safety officer so that we're able to have more of a formalized approach of when errors occur and when there are trends. Are these things that are related to system operations such as EHRs, pump programming, the way we dispense something overnight, or is it more of a local behavioral or cultural type issue that needs to be handled in a different way? Those have been two huge gains to our team to set up good, strong infrastructure. And I would say the third is having a pharmacy informatics and automation manager. Before, when issues were coming up with IT systems, the local leaders were having to troubleshoot that and, making requests to change things that maybe had a downstream effect on another pharmacy that they weren't aware it would have. And so funneling those through a singular person who can manage and mitigate what the changes need to be and what they are has really helped to alleviate some time from those operators and also alleviate some rework so that as we're making decisions, we can make decisions that fit the needs of all the different pharmacies, not just one individual one.
Yeah, and I think Systemness is really an evolutionary process, and it sounds like you're approaching it as such. So, can you talk a little bit about how you develop your comprehensive pharmacy strategy and how maybe that's transformed over time?
Sure. So I really think our comprehensive pharmacy strategy has been the compass to how we wanted to create our system leadership structure and then how we wanted to integrate our local operators into that. Bottom line, at the end of the day, we are all McLeod Health Pharmacy employees, but we have an obligation to serve our local hospitals or communities, wherever we're planted, to provide those operations. What we really tried to do was change our thought process of I am not only here to support my local hospital or local communities' needs and their strategy, but I'm also here to support pharmacy's comprehensive goals. By really laying out that plan to all of our operators in the pharmacy spectrum and to all of our CEO counterparts and leaders, we're able to give them more clarity in what are our goals and how do we get to those goals. It's very easy for us to say we have an infusion strategy, we have a retail pharmacy strategy, we have, a clinic administered meds strategy, whatever it may be, to be able to provide our patients the meds that they need. But really talking about what are the steps that are out there that it's going to take for us to get where we're going. And so, we're constantly having either local leaders or myself or some of our system pharmacy leaders really get out and get into the weeds of what is the pharmacy strategy and how are we going to accomplish these things with our key stakeholders like finance, rev cycle, our clinic operations. That's been a huge gain for us in kind of formatting what our strategy is. For so long, we've thought of pharmacy strategy being tied to acute care operations. And as we all know, the ambulatory sector is where pharmacy really can thrive and begin to grow and create connectivity for patients with revenue generation as an added bonus. And so getting ourselves embedded in with the clinic stakeholders and really helping them see what having these different infrastructure and pieces of pharmacy can provide to their patients, I think has really been invaluable in mapping out what that strategy looks like as a whole.
What key components of that strategy do you think have had the greatest impact on either patient outcomes or operational efficiency so far?
I think a huge piece of the strategy has been creating our med access pathways. So for a very long time, the way that med access has been handled really has been, here's your prescription, we'll do the prior authorization when whatever pharmacy you go to requests it back to us. And at that time, we'll hope that you can afford your medication. I think that's the kind of the approach that all of us had taken for a very long time across the country until we realized that patients leave our practices or they leave our hospitals and they can't navigate the ability to be able to ensure that their prescriptions are covered or ensure that it's going to be a financially viable option for them. Creating that med access team has really helped navigate patients to decrease prescription abandonment, but it's also alleviated some burden off of our frontline office staff who was just kind of having to take that on in addition to seeing patients and trying to keep up clinic flow and trying to make sure there are access to appointments and all of the other things that they're responsible for in their day to day. We've said, hey, can you also take this really complex process and try to make sure this patient gets this complicated med that costs a whole lot of money? We found that, that wasn't working. And so patients were seeking help from outside the health system, or even our practices were seeking help from outside of the health system. And many times that led us to have patients who were, seeking services for medication administration or medication access elsewhere. There's nothing wrong with good competition. There's nothing wrong with patients having a choice, but we believe that keeping them connected in our health system helps their journey to be much more seamless and really helps them to understand their therapies, be able to access them, and then also be able to be monitored for them. Because as we all know, these new specialty meds that have come out over the last 10 years require a whole different level of monitoring and upkeep and maintenance, and they're expensive. And so if you aren't continuing to receive therapy and being compliant with therapy, it's a lot of loss from a financial standpoint to only invest in those meds every other month or try to space your meds out so that you can afford them. And I think that med access team has done a great job of leveraging all the resources that it can to really make a difference in patient outcomes, both from med access side and also from their clinic experience side.
What's the composition of your med access team? What kind of people do you have on it?
So we have a variety of people on there. We have some people who have, nursing backgrounds, some people who have benefit investigation backgrounds, but pharmacy technicians really are the kind of the backbone of that team. They have this unique skill set where they know about the meds, they know about the complexity of navigating the world from prescription is written until patient receives it. They're able to have conversations with the insurance companies and able to field a lot of things without having to elevate that to the level of a pharmacist or a provider. So when we think about a skill mix perspective, they really do bring so much to the table for that team and are really able to navigate so many things for our patients and for pharmacists and providers, and are a valuable asset to us.
I think that's fantastic. Maybe expanding on that a little bit. What other ways does McLeod's pharmacy team support patients, maybe beyond medication dispensing, as they go through that entire healthcare journey?
Yeah, that's a great question. So even beyond dispensing and med access, we also have meds to beds technician, which in my mind is another arm of med access, so to speak, but it really is unique how these technicians are able to work alongside case managers, providers, and patients to make good decisions about how we're going to be able to get a patient out of the hospital and hopefully keep them out of the hospital. That program has been incredibly beneficial to our cardiac population. Also, when we were experiencing some major narcotic shortages across the country, we were able to begin to service our own surgery patients to prevent ED bounce backs or, other issues with pain control after orthopedic surgery by kind of using that team as the liaisons to our patients, not only on the inpatient side, but even in our same-day surgery areas. We also use pharmacy technicians as medication history technicians, and we have them in most of our EDs across the system. So as patients come in, they're able to help to get a very clean list of data so that when the providers go to reconcile orders, we're minimizing any medication errors or any confusion that may cloud the provider's judgment or ability to make good medical decisions because they're unsure about what the patient's been taking. Again, having a technician in that space really allows an extension of pharmacist time, nursing time, and provider time. And they really are the right people to do that work because they understand medication names, they understand common doses, and are able to kind of detect discrepancies that a patient may have on their list and try to get those resolved before a provider or a pharmacist or a nurse having to spend the time getting that done.
How are you doing with recruitment and retention of your pharmacy techs? Because as we work around the country, so many areas of the country are really struggling with that.
Yes, and we are right there with them. One of the things that we're desperately trying to work on is how do we create a lattice for those amazing professionals who have for far too long just been put in a box of pharmacy technicians. They're so much more than that. They are IT analysts, they are troubleshooters, they are, chart abstractors, they're analysts for our finance teams, they're analysts for our 340B teams, and really beginning to display that the complexity of their work is much broader than just dispensing medications. While that alone is complicated enough, the other areas that they're beginning to venture into are very, very complex. And they have a unique skill set on top of being able to be great analysts. They have this unique skill set of they know medications and they know the complexity that comes along with trying to manage a process that includes somebody's medication data.
Yeah, absolutely. I think it's we can't really say enough about the contribution that the pharmacy techs make, but I think you're right on. Sometimes it's out of sight, out of mind with the organization, and they're not really recognized for everything that they do.
Absolutely.
You mentioned a couple of partnerships, IT and finance. Any other successful partnerships or initiatives that have emerged between pharmacy and other areas in the organization as you work towards systemness?
Yeah, so IT is a really big one for us. I don't know how many people have sat down and kind of mapped out their ecosystem for all of the different IT applications that make our pharmacy enterprise run. But we sat down and did that exercise, and it is remarkable how dependent we are on IT and technology to drive safe, efficient, and I guess financially intact operations within a pharmacy. So we knew very early on that if we were going to begin to be successful in changing the way we looked at pharmacy and kind of succeed at our enterprise strategy, we were going to have really strong relationships with IT, and we were going to have individuals who are pharmacists, pharmacy techs, who can work alongside our IT analysts to be able to architect systems in a way that operators can utilize it most appropriately. We've had to work with different sectors of the IT team that historically, have not had that much integration with pharmacy. So our ambulatory team, for example, really trying to beef up our partnerships with all of our clinics has led us to need to have certain workflows that come out of, the ambulatory side of pharmacy, not just the traditional pharmacy pathways. Looking a lot more at our e-prescribing rates and, what's out there for providers to be able to order. How do we give them transparency into pricing or transparency into where authorizations sit and those types of things so they can make good decisions. Building that partnership with IT has really been incredibly valuable, not just in the pharmacy space, but also ambulatory. With finance, it's really been more about finance and rev cycle. And so beginning to work with the rev cycle team to understand what are our challenges around authorizations? Where are we seeing denials and why are we seeing them? Is there something we can do to help on the front end with providers as they're entering therapy plans or deciding on different therapies that would help decrease our denials long term? We've set up kind of a multidisciplinary committee that looks at denials every other week, and we talk about what was the root cause of this one and how do we keep it from happening longer term. I think those partnerships with kind of those frontline rev cycle analysts alongside our pharmacy team has helped us to understand more about their work and helped them to understand more about pharmacy so that we've been able to decrease our denial rates on the medical benefit side of pharmacy as well.
Yeah, I think that's so important. I remember, when I started a new chief pharmacy officer position once, I went and spent two days out at RevCycle and just sat with the RevCycle personnel and watched what they did. And I thought, oh my gosh, it's amazing. We ever drop a clean claim. Everything
I
they
know,
have to
I
do.
know. Those are some very, very difficult positions to have. Those people do amazing work, and it's sad sometimes how difficult their work is, and how they really, get bogged down into just rework. And that's what we're trying to focus on, I think, with that team is how do we prevent the rework? How do we just get the clean claims out the door? How do we have the authorizations before we treat the patients? And really thinking about it more in a proactive way instead of doing an autopsy on something that's already been denied. And so I think that's been the value of bringing together minds who think differently and, know different things and really putting them together so that we're looking at it from the best way possible for the organization.
How do you have your pharmacy IT resources structured? Are they part of pharmacy? Are they part of IT?
So we have newly created an informatics team within pharmacy, and that book of the work lives on the pharmacy operations side. So we have an IT pharmacy manager, a pharmacy technician who's an automation analyst. So they do all of our inventory management, automated dispensing cabinet work, and then two informaticists, one of which focuses more on acute care operations and the other which focuses more on ambulatory, beacon, and ultimately will also focus on our outpatient pharmacies as well. On the opposite side of the house and under IT, that's where our analysts live. And so these are truly the builders. We kind of use the informaticists as the troubleshooters and the architects, and we develop what we would like for the analysts to then build. That's worked really well for us because we found very early on that, we would have tickets that would get placed by anyone across the organization. It would get assigned to an IT resource. And maybe the ticket had the best of intention, but the way that we wanted that work to actually get done so that it would meet the needs of the patient, meet the needs of the requester, and, not cause any disruption within pharmacy, we had a little bit of a disconnect. And so adding that layer of a pharmacy informatics team that knows pharmacy operations and is embedded in our strategy, our tactics, and our goals has really helped to streamline IT's workflow because they're doing a lot less rework, and then helped us to kind of manage the expectations of people who are requesting different IT changes related to medication management.
That's great. And, I want to be respectful of your time. I really appreciate you being on the podcast. Maybe we could wrap up with, just kind of your thoughts on what other opportunities you see for deeper collaboration between pharmacy services and other departments as places begin or continue in their evolutionary process towards systemness.
Yeah, so it's a great question. I feel like that, we're not just trying to achieve a pharmacy strategy and we're not just trying to transform pharmacy, but we really are trying to transform lots of different areas of the organization. And without having those good partnerships and kind of identifying who are your key stakeholders going to be straight out the gate, the ones that are most important to helping you become successful, the ones who your operations depend the most on, I think is one of the big things to consider for everybody. One of the things we haven't touched on is providers. Of course, they are ones that you've got to have a really great, strong relationship with, and you've got to listen to them about what they need your operations to provide for their patients and for their area of practice, be it acute care, be it ambulatory. Really getting feedback from them, I think is one of the best guiding compasses that you can have because you've got to be able to meet their needs. IT, finance, rev cycle, your clinic operators are all incredibly important as well. But the person with the power of the pen, we all know, has been one of our biggest advocates and greatest partners within pharmacy for years and years. And so having that provider group kind of get buy-in around what pharmacy services is trying to do for their practice and for their patients is incredibly important as you try to achieve those goals.
Okay, one more follow-up to that.
Okay.
How have you approached your system P&T activities?
Oh, that's a really great question. So we actually were a little ahead of that curve. We converted to a system PNT in 2016. So before we became really a system pharmacy service, we did at least get our medical staff and our providers to approve a singular PNT committee that had historically been managed by the pharmacy affinity team and the clinical pharmacy manager for the organization. One of the gaps that we identified very early on in our system work is that we had excluded our ambulatory providers. And so we have now kind of encompassed them into the process. And so that's evolving. But that is one gap that we did have. We were focused primarily on acute care and infusion services when we really needed to think about our ambulatory docs too and what they're providing in their clinics, and is that the best place for the patient to get it? And if so, do we have good processes around documentation, monitoring, revenue capture, all of those kind of things?
So do you have a single formulary then that encompasses both acute and ambulatory meds?
So we do not yet, but that is what we are working on. We have a singular formulary for acute care, of course, with some stocking variation if a facility doesn't offer that service or doesn't have that type of patient. And then we have a singular formulary for our outpatient infusion centers, but we do not have one yet for our outpatient clinics. That's what we're working on now.
Well, Jenna, this was excellent. And again, thanks for being on the podcast today and sharing McLeod's journey towards systemness. And good luck with everything you have going on in pharmacy, supporting that journey, because it's a lot.
Yes, it is. It's fun. We love doing it.